Good afternoon. Greetings from the Prasad Institute of Medical Sciences. Let us spend the next few minutes talking about pre-hospital care. Medical emergencies are time critical. They need plan, practice, and perfection to tackle them. The knowledge must be concussed and you must be able to practice it to perfection. Usually, the person who's tasked to achieve this for the injured is the first responder. His role is extremely vital because simple things done in time are far more important than too much being done too late. The example of this is in the Ramcharitmanas, where the Lord is about to break the Shiv Dhanush. The description goes like this कि का वर्षा जब कृषि सुखाने समय बीत पुन का पछताने. So much is the problem with the depression with Janki ji. असजिय जान जानकी देखी प्रभ पुलकेलक प्रीत विशेषी कुरई प्रणाम मनई मन कीना अति लाघव उठाए धन लीना. See the speed. लेत चढ़ावत खैंचत काढ़े काउ न लखा देख सब ठाड़े. लेना चढ़ाना खैंचना कोई देख ही नहीं पाया. तई छन मध्य राम धन तोरा भरे भुवन धुन घोर कठोरा. That is the level of perfection that you need in your first responder to tackle the medical emergency. Where an accident occurs every minute and death due to an accident every 4 minutes, 70% of the victims never reach the hospital. So the first responders need to be trained in sufficient density and organized to respond in a timely fashion to achieve this extremely important pre-hospital care. If India invests in pre-hospital care, then it will have to spend rupees 400 per disability adjusted life year saved. Compare it with rupees 14,000 if we invest in hospitals and rupees 40,000 non-recurring if we invest in primary prevention. But the US did invest in primary prevention by making two-way highways, making head-on collisions impossible. Thus, vehicles colliding at 30 and 20 would make the collision force 10 and not add up to 50. Results were that they have become 23rd in trauma deaths as compared to being first before this investment. So when I was the director of VPIMS Patna, we tried this creating an ideal first responder and training and using him. The ideal first responder we chose was a auto or a auto driver. Now, AIMS Patna trained about 400 auto drivers, calling them Sankat Mochan Nagriks. AIMS Patna created a downloadable app called Sankat Sanket with pre-written messages indicating the information of the emergency. Like, I have an accident injured near me. On clicking the mobile, the information would go to the police, the fire services, AIMS Patna casualty, and all the Sankat Mochan Nagriks with the date, time, and the GPS location of the mobile. The nearest responder would move in, provide first aid, and transport the injured appropriately. Later, we trained about 3,600 Sankat Mochan Nagriks in Siwan. And here, AIMS Patna got an appreciation letter from the Health Minister and the Prime Minister and got the Socrates Award, which was actually awarded by the committee which awards the Nobel Prize. The training consists of recognizing the sources of disaster. Our good old chaupai, Chiti Jal Pavak Gagan Samira, Chiti Prithvi, Jal water, Pavak fire and electricity, Gagan air rate radiation, Samira winds, and Panch Rachatya Adam Sarira, that means from virus to human beings, the human beings being the most dangerous, are all sources of disaster. And we must act to reduce the risk of such disasters. And this exercise is called as risk mitigation. And our first responder should understand and, and help in conducting risk mitigation policy of the health system. Then he must know how to save himself first. He must know exactly what best to do and practice doing it. Then he must know how to help contain disaster. Somebody was shooting at a metro station and there was a announcer saying that there's a shooting on platform number 3. Please get into the train that is standing there. So by just getting into the train, many were saved from the bullets. And that person who was Kasab was shooting, and that person was actually awarded. So help contain the disaster. Then move yourself and victims to a safe place and call for help. AIMS Patna developed this Sankat Sanket use. The call message basically contains what has happened, where, when, how many are injured, what help is needed, and what is the safest route to the site. Then you classify victims into walking, talking, breathing, and bleeding, broken, dying. You must take help from the walking, talking, breathing and help the bleeding, broken, dying. Then you must transport appropriately, quickly, and with full information, including your contact numbers. Bleeding occurs because the pressure P inside the blood vessel is higher than the pressure small p outside, and there's a rent in the blood vessel. So if you increase the outside pressure using a compression bandage and decrease the inside pressure by elevation, then elevation and compression bandage will arrest the blood loss. And if you maintain it for sufficient period of time, for example 8 minutes, then the rent will seal by the clot and the bleeding will stop. So no need to panic, just press and the bleeding will stop. Then the use of tourniquet. So the 4 principles of use of tourniquet are: avoid it as far as possible. First principle. Always apply on the single bone. 3. Not too tight or you will produce nerve palsy. Not too loose, because otherwise veins will stop, arteries will keep pumping and the bleeding will increase. And finally, you must ensure release of the tourniquet of 5 minutes every hour, because if you fail to do this, there will be gangrene. And we developed the skill of tying a compression bandage and tourniquet in our first responders. So bleeding leads to shock, and you should not diagnose shock. Shock should always be diagnosed by suspicion, not by the cold, clammy, pulseless patient, a falling blood pressure and gasping patient. For if you diagnose shock by these physical signs, you have diagnosed shock for post-mortem purposes. Treatment is replace blood by blood as soon as possible, as fast as possible. The American army saying is put in the drip first and see the pulse later. If there's no blood, use plasma. If no plasma, use plasma expander. If no plasma expander, use Lomodex. If no Lomodex, use Ringer lactate. But replace the blood volume. Then monitor your patient and provide nursing care. Now, fractures of the cervical spine are life endangering. because if the cord gets injured above the phrenic origin, then there is no intercostal muscles and no diaphragm, and the patient will die. So if he is wearing a helmet, we must know how to remove the helmet, and you must remember that you need at least two people to remove it. One maintains the chin sternum relation, and the other actually removes the helmet. Then the use of cervical collar. The normal cervical collar will prevent lateral flexion and forward flexion and extension, but a four-post collar will also prevent rotation. Then this is how you put a pillow. The height of the pillow is between the cheek and the bed, and that keeps the cervical spine straight in a coma position, because he will vomit out and not aspirate the vomit. Then if you want to prevent rotation of the forehead, you bind the forehead to the stretcher, and that will prevent rotation of the cervical spine. So this is caring of the cervical. This weird diagram is, these are two people standing across the patient. Here is the site of the fracture, and they are hand shaking to support the fracture. By the other hand, this fellow will pick up the chest side, and this fellow will pick up the pelvis side, and this is called as the handshake method of lifting the patient who has a fracture of the spine. Otherwise, a spinal fracture without paraplegia will become spinal fracture with paraplegia. Then the upper and the lower limbs, if they are injured, upper limbs are splinted to the body, lower limbs are splinted to each other, or if you have a splint, then use the long distance splint. You must note the neurovascular status. You must grossly reduce the fractures and dislocations, and you must cover the wounds and give antibiotic. If your patient is breathless or blue, the possibility is that there is an intrapleural space occupying lesion. It can be air, pneumothorax, it can be blood, hemothorax, and it can be both hemopneumothorax, it can be fluid, pleural effusion, it can be pus, empyema. Now, this compresses the collapsed lung, and the collapsed lung has all the perfusion of the right side of the heart, because the peripheral vascular resistance there is low. And so there is all blood in the collapsed lung but no air, and all air in the normal lung but no blood. Therefore, because of this dissociation between the ventilation and perfusion, the person is getting blue. So you give positive pressure respiration, because that will decrease the collapse of the lung. You give oxygen and you decompress the pleura, either by a 16-gauge needle in the second intercostal space or an intercostal drainage. And if there is a flail fragment moving opposite to the respiration because of a double fracture rib, stabilize the flail fragment immediately. This is life-saving. If there is a listless, non-responsive patient, not breathing, no pulse, no heart sounds, but the pupils are still reacting and are not dilated and fixed, then you give cardiac massage, 60 per minute on the lower part of the sternum, pressing it 3 centimeters and allowing it to bounce back, and patient is on the hard surface, and then positive pressure breathing at 12 per minute. That means for every 4 compresses, one breathing. And if you aren't able to revive the patient in 30 minutes, then you can declare him dead. And if the pupil is dilated and fixed and non-reacting to light, then don't waste your time. The patient is already dead. Finally, before transporting him, put the patient nil orally, clean and cover the wounds, give analgesia and antibiotics, transport appropriately, which means nearest where all the problems can be managed and there is vacancy. This is exactly what is done in the shock trauma center in US. In 3 minutes, you are at the correct place. And then the most important thing is the transport with full information, including your contact numbers.